the diabetes and heart from a diabetologist perspective. I'm not a cardiologist. Let me try to do some justice for this topic. Yeah, the topics of discussion is the cardiovascular disease in diabetes and talk something on the pathophysiology of heart disease in diabetes. What are the cardiovascular disease risk calculators? And we talk about diabetes and hypertension, diabetes of dyslipidemia, diabetes and heart failure, and prevention and management strategies and summary. And next slide, account for most morbidity and mortality in diabetic patients. Diabetic patients are known to have 2 to 4 times increased coronary artery disease risk, and coronary artery disease has been reported to occur 2 to 3 decades earlier in diabetic patients. Type 2 diabetes shares several risk factors in common with coronary artery disease, such as age, hypertension, dyslipidemia, obesity, physical inactivity, and stress. So, India is predicted to have the greatest CAD burden and global burden of this disease. The hypertension present in almost 70 to 80% of diabetic patients. Dyslipidemia, low HDL, high LDL and triglycerides, and obesity, central obesity, almost 80 to 90%. The CKD and smoking. Diabetes is a major risk factor for CVD, and CVD is the leading cause of death in diabetic patients. The presence of comorbidities again increase the CVD risk in diabetes. If you look into the spectrum of the cardiovascular risk in diabetes, what is the prevalence of these diseases? And this diagram is clearly showing one is the coronary heart disease, almost prevalence is of 14 to 21%, most frequently reported from the cardiovascular disease and most lethal one. Risk of death from CHD is higher in women than in men. Again, very next important topic will be that heart failure. The prevalence of 19 to 26% in diabetes. Second most common initial manifestation of a cardiovascular disease in type 2 diabetes. And the risk of heart failure is up to twofold in men and fivefold in women. Then talk about the peripheral artery disease. Prevalence is around 16 to 29%. Most common initial manifestation of the cardiovascular disease in type 2 diabetes. Prevalence is 1.8-fold higher in women compared to men. Stroke again, prevalence 8 to 12%. Almost it is the second most frequent cause of death in patients with type 2 diabetes and coronary heart disease. And prevalence is similar in both men and women. When you look at retinopathy, prevalence 34%, most common microvascular complications of diabetes, responsible for the 2.6% of cases of blindness worldwide. And neuropathy, again, looking at the cardiac autonomic neuropathy, prevalence is 31 to 73% with the diabetes. No difference in prevalence between men and women. Again, nephropathy, 29 to 61%, leading cause of end-stage renal disease. And female sex is a risk factor for nephropathy in type 2 diabetes. This is a nutshell. Move on to the next slide, please. The diabetes and heart. The cardiac dysfunction is often clinically silent in diabetes and frequently not detected until later stages of the disease. This is one of the most common issues with the diabetes. Many times people think they're all right, as Dr. Panni said, people just keep jolly well and they sleep in the night, don't get up in the morning. So many people think that heart is all right as long as they start doing all the routine work. Almost 5 decades ago itself, the Birmingham Heart Study established the link between diabetes and increased risk of heart failure. Diabetic cardiomyopathy, impairments in cardiac structure and function, independent of the macrovascular complications of type 2 diabetes like hypertension, CAD, and atherosclerosis. Very important is this cardiomyopathy is independent of the macrovascular complications. So look at the multifactorial contributors to the diabetic cardiomyopathy. One on the inflammation, on the other hand, you look at the reactive oxygen species and oxidative stress, altered substrate utilization, mitochondrial dysfunction, myocardial cell death pathways, autonomic dysfunction, neurohormonal mechanism, and altered insulin signaling and advanced glycation end product. So structural and functional impairment of heart in diabetic patients. When we talk about the function impairment, start with the LV diastolic dysfunction followed by systolic dysfunction. Again, structural impairment, cardiac fibrosis, cardiac hypertrophy, and impaired coronary microvascular perfusion. Look at the pathophysiology of diabetic heart disease. So diabetic driven atherosclerosis. Then look at the The initial factors being hyperglycemia and advanced glycation in products, dyslipidemia, oxidative stress, inflammatory response, and diabetes. With anti-diabetic drugs and antioxidants, it can have an NLRP3 act on interleukin 1B and caspase 1, leading on to the endothelial dysfunction, inflammation, platelet activation and aggregation again, and the net result will be atherosclerosis. Next slide. What are the ESC guidelines say on the cardiovascular risk certification in type 2 diabetes? Almost, uh, they're classified in low, moderate, high, and very high CV risk. And start with the low cardiovascular risk, patient with type 2 diabetes not fulfilling the very high risk criteria, and probably we come from the top. The very high risk cardiovascular risk means patient with type 2 diabetes with a clinically established atherosclerotic cardiovascular disease or severe target organ damage or 10-year cardiovascular disease risk of 20% or more using the score 2 diabetes. So the high cardiovascular risk category, patient with type 2 diabetes not fulfilling the very high risk criteria, but the 10-year CVD risk is 10 to 20% score to diabetes. Moderate cardiovascular disease, again the patient not meeting the very high risk criteria, and 10-year CVD risk of 5 to 10%. And low CV risk, patient with type 2 diabetes not fulfilling very high risk, and 10-year CVD risk of less than 5% using the score 2 diabetes. This is how the cardiovascular risk certification in diabetes according to the 2023 European Society of Cardiology guidelines. And the CVD risk calculators, you can see the Framingham risk score. Most of you will be familiar with the Framingham risk score. And the risk prediction tools are usually developed with two main objectives. One is to assist the healthcare professional in the clinical decision making process. Second, to inform the individuals about the risk of developing an outcome. And the Framingham risk score appears to have a reasonable validity in South Asians. And this figure shows an FRS calculator. And you can see the, uh, almost estimation of the 10-year cardiovascular risk based on the age, like an HDL cholesterol, total cholesterol, systolic blood pressure, and smoking history and diabetes. Then the step one, step two, if they, based on the score, then they do on the total, total points. The 10-year CVD score is assessed, and it's again step three and step four. It goes on like this, and so it's all available in the net friend, and you can go through that. Next one. So this is again ESC guidelines, score to diabetes, estimating the 10-year CVD risk already said, and generally the score to diabetes integrates information on conventional cardiovascular disease risk factors, with age, smoking status, systolic blood pressure, again, and total and high density lipoprotein cholesterol, and again with diabetes specific information, the age at diabetes diagnosis, HbA1c and EGFR. Suppose in patients aged 40 years and plus with type 2 diabetes without ASCVD or severe target organ damage, it is recommended to estimate the 10-year CVD risk using this score to diabetes algorithm. In these patients, risk factor for ASCVD should be evaluated on an individual basis. So, patient with ASCVD or severe to target organ damage, you can use this. And if it is more, with 20% and more percentage, they call it very high risk, and 10 to 20% high risk, 5 to 10% moderate risk, and less than 5% are low risk. And the target organ damage usually they call as basically involvement of the all three, the microvascular complications as well as the EGFR of less than 45 or the microalbuminuria of more than or the proteinuria more than 300 milligram per grams. So the presence of three different microvascular complications also, like might be retinopathy, neuropathy, and nephropathy. So diabetes-driven ACV, you can see men and women, the all-cause mortality in per 1,000 person years. So we can look into they look in the left-hand side, there's no diabetes, and right side, diabetes definitely, obviously, the risk is higher in people with diabetes. So diabetes is associated with the increased risk of MI across the spectrum of acute coronary syndrome, even in which diabetes may affect more than 1 in 3 patients. Patients with diabetes have worse CVD outcome after the HPS event. We talked about diabetes and hypertension. Hypertension is generally we call as that they are deadly duo. Diabetes and hypertension. Diabetic patients develop hypertension. On the other hand, hypertensive patients can also develop diabetes. So hypertension is twice as common in people with diabetes. Diabetes and hypertension both share the same common pathophysiology like endothelial dysfunction, arterial stiffness, inflammation, and oxidative stress. On the other hand, diabetic kidney disease leading to salt and water retention, which in turn raises the blood pressure, insulin resistance, and sympathetic overactivation and ROS dysfunction can also increase the blood pressure. So diabetes and dyslipidemia, very common in type 2 diabetes mellitus. You can see the combination of affecting around 70 to 85% of patients with the more atherogenic lipid profile that include hypertriglyceridemia, high levels of poor lipoprotein B, non-HDL lipoprotein, and low dense LDL and low HDL. Understanding diabetes dyslipidemia is important as it can account and bring on cardiovascular event even before the diagnosis of diabetes. Even the stage of pre-diabetes, we see a lot of people with coming with this thing and which can increase the risk of cardiovascular disease. So diabetes and heart failure, that last decade, almost 5 to 10 years, we have been frequently talking about the heart failure, the pump, pipe, and filter. So the heart failure is often talked unappreciated complication of diabetes. Risk factors for heart failure and diabetes are poor glycemic control, uncontrolled hypertension, hyperlipidemia, obesity, microalbuminuria, renal dysfunction, and ischemic heart disease. Again, talk about the cardiomyopathy, ventricular dysfunction in the absence of coronary artery disease and hypertension. Please note this, ventricular dysfunction occurring in the absence of coronary artery disease and hypertension. The mechanisms being RAS activation, mitochondrial dysfunction, oxidative stress, inflammation, changes in the intracellular calcium homeostasis, as well as formation of advanced glycation end products, increased FFA utilization, increased oxygen consumption, and decreased cardiac efficiency. The heart failure, diabetes and heart failure. Next, we talked about the different complications and how do we manage. We have learned how diabetes increases the cardiovascular risk. We learned about what is diabetes and dyslipidemia, diabetes and hypertension, and diabetes and heart failure, and what is the pathophysiological mechanism by which it being caused. So, the importance of the risk reduction is important. The figure you can see almost multifactorial risk reduction is very important. Weight control, healthy diet, physical activity, smoking cessation, glycemic control, blood pressure control, lipid control, and protecting kidney function. Optimal cardiovascular risk reduction in diabetes involves again the glycemic control, reduction, the blood pressure control, lipid control, and therapies to protect kidney function. The weight management is very important. Smoking cessation and lifestyle modification, including the healthy diet and physical activity, is for all recommended for all patients, diabetic patients, with additional pharmacological therapy as needed to achieve the cardiovascular metabolic risk factor. Next, so the pharmacological intervention talked about the hypertension, management of hypertension phase, ARBs, ACE, calcium channel blockers, and diuretic. The preferred telmisartan, azilsartan, again to be first line agents in combination therapy used in patients with existing cardiovascular disease, CKD, or other complications are used when patients are not responsive to combination therapy or ARBs, ACEs are used. Again, calcium channel blockers, cilnitine, amlodipine, diuretic used in case of resistant hypertension and in elderly patients. So the management of dyslipidemia again, okay, you can see the different uh, the patients with diabetes are high risk of diabetes with dyslipidemia, CV risk assessment and LDL measurement, and necessity for lipid lowering therapy. Expected reduction in LDL cholesterol, you can see up to 50% you can use the statin, statins here, and other statins. Also here, 50 to 65% statin plus estimobile fixed dose combinations are also available now. You want to reduce LDL cholesterol, 65 to 80% statin, estimobile, and bempedoic acid, a new one. And in fact, we have done a trial in all trials. It is bempedoic acid, and again, the more than 80% is statin, So by again PCSK9, the triglyceride high, you can triglyceride lowering therapy uh, are considered fenofibrate. The prevention of cardiovascular disease in type 2 diabetes. We talked about the disease prevalence and disease impact and disease burden, disease pathophysiology, and different manifestations of diabetes and heart, like coronary artery disease, and again cardiomyopathy, hypertension, dyslipidemia, heart failure. And the primary prevention guidelines, you can just look at all things repeated, everything all of you know. The physical activity, perform at least more than 150 minutes per week of moderate or more than 75 minutes per week of vigorous physical activity. Aspirin usage, low dose aspirin for primary prevention, now reserved for select high risk patients only, not as a routine primary prevention. Type 2 diabetes control through diet and exercise, metformin and SGLT2 inhibitor and GLP receptor agonist. Diet is very, very important. And the tobacco usage to be curtailed, and the cholesterol reduction and reduction in the blood pressure. In the 2020 years guideline also says that person-centered care, including shared decision making, goes beyond maintaining active person consent to decision and the person's participation to the development of therapeutic plan. Not that one way or it's a monologue, a dialogue. Involve the patient, explain to them what are all the risk factors involved and what are the goals we are planning to set in. And so, what are the various strategies available managing that, and what are the various strategies in risk reduction? You can see the pictures almost, disease management to advance the life and health related quality of life is very, very important. Generally, when you manage any patient with diabetes or heart disease, we talk about all these numbers. We talk about sugars, cholesterol numbers, BP numbers, but we do not talk about the quality of life. Quality of life is very, very important. It's one of the important pillars of diabetes management. Should ask the patient, how do you feel today? What are all your other functions? Did you sleep well? And how basically any therapeutic strategy should aim at improving the quality of life of the patient. You're not doing anything just only to improve the numbers and not improving the quality of life. It's not of use. So just all the colleagues keep all the guidelines in the back of your mind. See that all these management do more benefit than the risk to your patients. Is again the management of ASCVD, satisfy the ASCVD risk using risk calculators such as ASCVD risk estimator plus Q risk to UKPS risk engine advanced and perform further ASCVD risk as using testing ECG, ankle brachial index, coronary artery calcium testing, manage ASCVD risk patients with high risk established cardiovascular disease. You can always use this in the GLP-1 receptor agonists like dulaglutide, semaglutide, and they are the preferred first-line agents in patients with PAD and obesity or obesity. SGLT2 inhibitors like MFA, DAPA, CANA, preferred first-line management in heart failure CKD with or without metformin. So this is to reduce the risk of ASCVD. These things are recommended to support the idea of multi-directional relationship between type 2 diabetes, ASCVD, and CKD, which may partially explain the benefit with these glucose-lowering therapies across different organ systems. Yeah, prevention of heart failure. Mainly, you can see the SGLT2 inhibitors, main therapy for heart failure, significantly reduce the risk of cardiovascular death and hospitalization for heart failure, regardless of diabetes status. And so the one that SGLT2 improves the glycemic control, renal protection, and quality heart failure, quality of life. Again, MACE reduction, hospitalization for heart failure, CV mortality, renal death, and blood pressure, body weight, all are reduced by the SGLT2. FDA labeled indication, type 2 diabetes, and type 2 diabetes cardiovascular disease, the MACE, hospitalization for heart failure, CV mortality, and type 2 diabetes, CKD, renal protection, hospitalization for heart failure, CV mortality. Again, hospitalization for HF or people with a reduced physical interaction and hospitalization for heart failure and CV mortality. So one of the therapeutic armamentarium apart from the GLP-1 receptor agonist and the GLP-2 was a major. So even though they developed an anti-diabetic drugs, now they have a plethora of actions and more beneficial seem to be in the terms of heart. Antiplatelet therapy in diabetic patients. The ADA recommends the usage of low-dose aspirin as primary prevention strategy in patients with diabetes and increased cardiovascular risk. more than 40 years, family history, hypertension, dyslipidemia, and alburia. Aspirin is in secondary prevention. ADA recommends low dose aspirin as a secondary prevention of CVA and cardiovascular events in all diabetic patients. Dual antiplatelet therapy for the secondary prevention of ACS in diabetic patients. Targets for control of glycemia and less than debate the AHA, ADA, ESA, and EA different guidelines. Less than 6 months pregnancy patients without significant hypoglycemia. Less than 6.5 children and adults and short duration of diabetes. And again, patient with microvascular complications less than 7%. Patient with limited life expectancy less than 8%. And target for blood pressure again is also varies and less than 140/90. Patient with type 2 diabetes, stable coronary artery disease with high blood pressure target, with a higher blood pressure target, less than 130/80. Patient with higher risk of stroke and microvascular complications, less than 140/90. Patient with diabetes and hypertension at lower risk of CVD. Is according to ADA, less than 130/80. Patient with diabetes and hypertension, higher risk of cardiovascular risk. And 110 to 135/85, pregnant women with diabetes with a pre-existing hypertension. Less than 120/80, patients would need lifestyle intervention. And 130 to 139, unless that 80 diastolic, not less than 70. Older people, age 65 years, and all treated patients 140/90, less than that. And younger patients 120 to 132 bar, less than 80. So the patient is over 70 years of age, 130 to 139, and less than 80. If they're able to tolerate it, and I think this can be maintained for older patients. The target for lipid control, okay, again, lipid LDL cholesterol reduction of more than 50% equal to from a baseline. Adults with diabetes or 10-year atherosclerotic of 20% or higher, according to ADA. Okay, and LDL cholesterol reduction more than 40% from the baseline. Patients with diabetes and atherosclerotic heart disease, cardiovascular disease, according to American Heart Association. Again, European Society of Cardiology, the LDL reduction of more than 50% from baseline and less than 70, or a LDL reduction of more than 50 from baseline or less than 55. Or less than 70 is patient with type 2 diabetes of more than 40 years with a age and high cardiovascular risk. And again, less than 55 is a patient with type 2 very high cardiovascular diseases. And LDL less than 100 milligram, patient with type 2 diabetes, moderate cardiovascular risk is according to ESC and EASD, less than 70 milligrams. Patient with type 2 diabetes and high cardiovascular risk, less than 55. Like patient with type 2 diabetes, very, very high cardiovascular risk. So I try to give you the hypertension guidelines, dyslipidemia guidelines, and glycemic guidelines and different things. Dear colleagues, I just tried to take you through diabetes and cardiovascular system, what is the impact, and now to summarize, atherosclerotic cardiovascular disease is the leading cause of mortality and morbidity in type 2 diabetes patients. Accordingly, several scientific societies have released clinical practice guidelines to assist health professionals in AHA risk management in patients with type 2 diabetes. Several models are also available for prediction of cardiovascular risk in diabetes. The current main targets for the control of glycemia, lipid, blood pressure levels in patients according to the most commonly used guidelines should be included in an individualist strategy to prevent CVD in type 2 diabetes. So most type 2 diabetes related cardiovascular disease may be prevented by lifestyle modification and use of adjunct drugs suggested by the major guidelines across the world. While some cardiovascular scores are useful, caution is also advised in using CV risk prediction models. So thank you very much. I will stop here to take up any questions.